Okay. You want to send me your request approval? There you go. Okay, thank you.
Thank you, sir.
So, to a certain extent, when I try to talk about um, some topics over and over, I know that I hope that you don't feel that I'm kind of stalling because that's not the intention. The intention is to really make sure that we've had the opportunity to just really sort of chew on it as much as we can. Okay. Um, and that you know there are many different ways to look at the same topic, same object. And the growth old way of saying is that you look at the coin that we have. You can be describing the quarter coin that we have. But when you look at the front and back, uh, when you describe it, it can be quite different, but it's both coin. And we have to be able to recognize how it is that we're talking about just different aspects of the totality of the concept. And what I wanted to start out today, we're going to spend a lot of time concept talking about actually anterior guidance because we talked about neutral zone, we talked about range of motion or envelope of motion, and then we're going to talk about smile design, which is now actually beginning to be more of the and clinical practice, and then the anterior guidance, and then we talk about the hopefully I'm gonna I'm not jumping over too much, and then restoration of the anterior teeth, lower anterior teeth. Um, but but what I wanted to kind of make sure that we start out today is page 146. And so we spent a lot of time at the beginning of this group when we started talking about Dawson's book, reading Dawson's book. We spent a lot of time about the joint and the muscles, understanding of the location of the muscles, the importance of the muscles and everything. What's also critical on our understanding of occlusion is these proprioceptors. Okay, and on page 146 on the left-hand column, he shows you the diagram of all the nerve innervations. Okay, and then one thing that I wanted to say is on the left side, the very first article that I mean the sentence that he says is note the term proprioception has been used almost universally in the dental literature to connote that what should be more correctly termed mechanoreception. Proprioception refers to awareness of a body part in space. Mechanoreception refers to sensory recognition of mechanical tension, compression, or torque applied in this discussion to teeth. Okay. Now, how he's trying to differentiate proprioception and mechanoreception, I understand that. And I would like to actually emphasize that it is actually both, meaning that proprioception, yes, is more related to the musculature, the way that he has described it. So, for example, if my arm is like raised up here like this, okay, even with my eyes closed, I have an idea because of my muscle proprioception, okay, that my arm is raised in front of me, not behind me. Okay? So that's the muscle proprioception, right? Now, Mechanoreceptors, what Dawson is saying is when the teeth are contacting, that's what they are supposed to feed to our brain. The funny thing that I spent some earlier morning going back and forth in the book is this mechanoreception is critical to how anterior guidance works. Meaning, it is the mechanoreceptors that's going to tell your brain, and this is obvious, but we still have to tease it out and think about it. It is the mechanoreceptors in the front teeth that tell our brain, hey, I'm touching in the front, you need to open up. And that's what gives you the anterior guidance disclusion. Okay? And that's where they say later on, we'll read the part where Dawson says it helps to protect the posterior teeth. Okay? But it's important to understand this mechanoreceptors or proprioceptions can be confused and overridden. And that's what we have to keep in mind as we move on with rest of the stuff that we're going to be reading. Okay, and I think it's important that we keep that in mind. Okay, mechanoreceptors. Another way that I describe to people is when your teeth come together, when you're eating, when you're talking, when you're trying to figure out what's in between upper and lower teeth by bringing them together to the front, okay, of your mouth. Okay, mechanoreceptors kind of give us a sensation as if I'm using my finger right now to touch my book, and then confirm with my eyes I am touching my paper. Very nice glossy paper of Dawson's book. Okay? But there's a limitation to what my finger can give me. The proprioceptors or mechanoreceptors on my fingertip, there's a limit to what it can give me. I need to confirm that with my eyes, my vision. But guess what? Our teeth do not have the secondary proprioceptor called the vision. So our teeth, when they come together, they function as if, okay, as if my finger is touching some object. And my finger can tell a lot about what it is that I'm touching without my eyes looking at it. Okay? However, as you know, if I don't have the confirmation of my vision, it is totally understandable why I would get confused or I would conclude in a wrong way what it is that I'm touching. Okay? And that is the difficult aspect of, or the limiting aspect of, of okay, of our understanding of this quote unquote anterior guidance that I wanted to share with you. Okay. So, I trust that you have read all aspects of the book. Okay. But, um, you know, so there's a couple of thoughts that before I go on to the next chapter, I wanted to read from this part of the book, page 146. I thought it was interesting because I thought that we read in a different part of the book something slightly contrary, and I couldn't find that. On the right-hand column on page 146, about halfway down, so it will be third paragraph. Okay, the paragraph that starts with Levy, okay, has also shown blah blah blah. Okay, that paragraph going down about halfway, okay, and then it's about 1, 2, 3, 4, 5, 6, 7, 8, 9, ninth line, far from in the middle of the column, far from being inert stone-like form, teeth have an internal system of sensors that can discern the slightest compression or torque. And teeth do bend and twist far more than we have realized. Okay? And so he's trying to convey to us that teeth are biological organs. Okay? Many now suspect that the formation of effractions, as an example, may be caused in part by microscopic chipping away of crystalline structures as the teeth is bent by occlusal forces. So here is a comment that he's making. He does not necessarily posit that that's how he thinks, but he's at least presenting to you all what I've always said about effraction, that there are many people who believe that effractions, class 5, non-carrier cervical lesions, are actually result of mechanical occlusal overload. Okay, I'm going to go down to all the way down on the right hand column again on page 146. Okay, the second from the last paragraph, it says a prime purpose of occlusal therapy is to achieve a peaceful neuromusculature. And I cannot overemphasize that. I cannot overemphasize that. Okay? Occlusal therapy will lack predictability unless the preciseness of the system is understood and the skills for refining occlusions precisely enough are developed. Okay? Okay. But I want you to know, I want you to keep in mind that as Dawson says, the prime purpose of occlusal therapy, the number one purpose of occlusal therapy is to achieve peaceful neuromusculature. Okay? That is so critical. We forget. In clinical dentistry, we forget that we have to make the patient happy by giving them aesthetically um, pleasing or expected appearance. Okay? All right? But I want you to know that really the important aspect of it is the harmonious neuromusculature. Because if it wasn't for that, as we all know, things will just break down. Okay. The last sentence on the right-hand column, on right-hand page 147, certainly a complete understanding of anterior guidance would not be possible without being aware of its relationship to each individual's envelope of function. So with that note, I want to move on to the clinical aspect of functional smile design, anterior guidance, and so forth. Okay. So we let's talk about functional smile design. Okay. So when we do the smile design, okay, um, first he talks about the mounted cast. Okay. And yes, I can't say enough about the importance of understanding how the upper and the lower jaw comes together in a orthopedically stable position. You notice how I'm trying to phrase that. It is important to understand how our jaw, okay, how our jaw comes together in an orthopedically bone to bone stable position first. The complex aspect of occlusion is because it is a result of many different aspects coming together. And I hope by now you're seeing that. It's not just the teeth. Teeth are stuck to the bone. So if the bone are not interrelated correctly, then teeth will have hard time. Okay? So how do we replicate how the bone-to-bone relationship is between the upper and lower without regards to the teeth? Well, that's where the mounted cast concept comes from, because what they want to do is to teach us how to mount cases in CR. So however we define CR, that we've gone through that before. I don't want to repeat it too many things. Okay. But it's really helpful if you look at CR as orthopedic home position between upper and lower jaw. And orthopedic home position from which all jaw movements can initiate from. Okay. Well, now, why is my jaw is obviously able to go back and forth, left, right, and even slightly back. Okay. But why is this home position most important? Because that's where it is able to rest. And so as I told you before, the folks in Las Vegas, they like to claim that by using electromyography, they can find this home position for the muscles. And that's where they want to build everybody to that. And to a certain extent, that is at least a good starting point. However, if that's all you think about, then as you know by now, it's going to fail, because you also have to think about from there, the jaw has the ability to go to different relationships. And that is the envelope of motion, how the jaw is moving and how they come together. Okay? So it is important that we so to me, once you understand, okay, how to relate what mounting in CR equals to the clinical observation of guiding the patient into CR, and observing how the occlusion is from the CR to CO, or maximal incuspation. Okay, to me, conceptually, you have done your mounting. Now, especially early on in your training, and certainly with me, if you don't actually have an articulated model, it is difficult to visualize and appreciate it. And we oftentimes forget where that CR is and so forth. Okay. However, it is not just cliche that the most useful and most accurate articulator is the patient's mouth. And the reason why we say that is because so many times when we mount cases, okay, number one, it is extremely difficult to get an accurate mounting. Number two, earlier we were just talking a little bit about the realities of our clinical dentistry is so different than how we talk about ideal dentistry in a group like this. We don't have time to do the mounting and all that. Okay? I'll be totally honest with you. When was the last time I actually mounted a case using a Facebook? In my practice, not in my teaching clinic, in my practice. Okay? I'll be honest with you. I'm vaguely thinking it was at least 10 years ago, if not 15 years ago. Okay? Now, I'm not suggesting that, I talk one thing and I totally do different things. No, no. I pay attention to CR. I most definitely want most of my patients to be in CR. Okay? But the clinical reality of it is that given my practice speed and the time, the patients that I have to see and everything, I don't have the luxury of mounting everything and moving on with that type of scenario in my cases. I think it's a great learning experience in exercise, but I don't want you to feel bad when you're in clinical dentistry in daily practice to make money, to make a living, okay? That you're not doing that, okay? That's the only reason why I'm spending time talking to you about it. You can still deliver optimal clinical work to the patient without having to mount the cases. That's what I'm trying to say here. Okay? But the concept of recognizing CR in your patient's mouth still has to be there. Just because we're not mounting does not mean that we take the bite as the patient gives to us and we just build upon that. If you do that, then you have completely failed. Okay? So when somebody tells me, oh, I restore everything to my habitual bite, maximum unicost patient or CO, okay? I hate to tell you, yeah, no, no, no. Those people still need to go back to learn how to do mounting, okay? So I just wanted to kind of emphasize that, okay? Okay, so um, let's go to page 151 on the third paragraph. Okay. He says, if there are posterior interferences that require displacement of the TMJs to achieve anterior contact, the result will be the potential for any or all of the following: overload on posterior teeth, hyperactive incoordinated muscles, mandibular side slide forward into anterior overload, excessive wear, hypermobility, and tooth migration, unstable dentition. All those are absolutely true. All those are absolutely true. Okay? Now, that's if you have a posterior interference. Okay? Now, that's what you're going to often find when you mount your cases in CR. Okay, Mylene? Yes.
Hmm. Hi. Yeah, I'm wondering about the mandibular slide forward into anterior overload. Like, why would it be anterior overload?
So, that's a very clinically relevant question. Okay. So let's say that you have actually reasonably textbook anterior guidance, meaning that your front teeth are touching um, at the same time as the posteriors in the centric relation position. I'm going to try to find the drawing. Page 160, figure 17-1. So you got all those dots in the posterior teeth contacting, and then the anteriors where the slides, where the lines come together. One line represents protrusive, one line represents uh, uh, lateral. They come together to the dot, and many people will say they are supposed to contact those spots. Okay? Now, if you have a posterior premature contact, okay, usually on the second bicuspid, second molar, okay, what the mandible will do is from a CR, from an orthopedic home position, mandible will, it's the easiest for the mandible to slide forward to avoid that posterior interference. it slides away from that interference. Now, usually it's not straightforward. There's going to be slightly lateral component to it. But when they slide forward, if your front teeth were already slightly touching, okay? But if the posterior interference is causing your mandible to go forward, that's when your anterior teeth are now touching more than it would have been designed to, or in an ideal anterior guidance. So now they are being overloaded. See, people who talk about anterior guidance, as I've said many times, they don't talk to you about the degree to which they should touch. If you're supposed to, let's just say, hypothetically, the anterior teeth are supposed to touch at 10 pounds per square millimeter. But because you're sliding off of the front teeth, by the time they are sliding into the front, now they're putting 20 pounds per square millimeter of force. That 10-pound overload over the ideal level is the overload. And this is the problem with anterior guidance folks. They don't define for you what constitutes or what evidence you have of overload. Now, Dawson does talk about it a little bit, so we'll get to that, okay? But they don't talk about it enough. And that's where the anterior guidance, I say, has led to more problems in dentistry. Because many people came to equate anterior guidance equal to anterior contact eccentric, and without defining how strong they should touch, it became an overload easily in so many cases. And they were never aware of it because they were not taught this how to differentiate an optimal loading versus an overload. I hope that helps you to untie the knot a little bit.
Sure, thanks.
Okay, thank you. Okay, so it is not uncommon when you actually mount a case or when you find somebody into CR in clinical setting that you take a look at them and then you see the picture of page 153 of that face mounted in centric relation. To be honest with you, face mounted obviously helps to orient the upper member of the cast, but in terms of seeing that bite discrepancy, it doesn't matter whether it was face mounted or not, because that's really a function of CR type of thing. Okay, now it is dramatic like that. You can see that. Okay, you need to know this happens far more than you realize. This happens far more than you realize in clinical dentistry. Most of the times, the thing about clinical dentistry is it's difficult to see this because we don't bother deprogramming them when we take a bite registration, when we take a look at them in the mouth. Okay? And certainly, a correct way to take a bite registration for mounting will involve deprogramming, right? Okay. So when you and if you use the word, as I said many times, if you use the word bite to the patient, most of the times they don't bite in their CR. They're going to give you their habitual bite, which is habitual means it's very well greased, very well oiled, programmed bite. Okay. So the important aspect of this is this. that when you mount the case in CR and you see this kind of discrepancy, or you see this kind of discrepancy in the mouth, what do you do next? That is the critical part, okay? Now, on the articulated cast, what Dawson is demonstrating to us here is that he will go through and he will equilibrate the cast, right? So that you have more even posterior stop first, right? And then he will do the wax up in the front, lower front, so that he can create in his mind, okay, the ideal relationship of the lower front to the upper, not incisal edge, but the lingual contour of the upper incisor. Go to page 157, figure 16-2, where there are all those planes on the maxillary incisor tooth. Look for the number 1. Dawson is saying that the lower incisor edge needs to contact that in centric relation. And in my opinion, respectfully, I disagree. Now, it may contact, but the contact itself should not be the primary criteria that we're shooting for. It may go there, or it may go slightly towards number 5, somewhere around number 5 plane. I don't think I want it to be at number 6 plane. But how much force it touches, whether it was 10 pounds or 20 pounds, that is determined by envelope of motion. Because if it touches, and then in envelope of motion, if it is touching too much so that there is interference, well, then what do? You're going to leave that alone? No. We just spent, a couple of chapters about neutral zone and envelope of motion and proprioceptors to understand how critically important that is. And this is the reason why Dawson's book is not as helpful as it could be. Because people look at this chapter and they're going to do their diagnostic wax up based on what this chapter 16, is talking about. But by the time they get to chapter 15, 16, they forgot about chapter 14 and the chapter 15. What makes occlusion difficult, but so much more satisfying once you get it right, is when you balance out all of the factors that we have studied so far. Okay, so this is why I don't just tell everybody go read Dawson's book. It tells you everything you need to know. I mean, if you read it critically like we're doing, I hope you feel that way. Okay, then yes, it gives us the opportunity to think about all these things and so forth. But the progression that he's making, he keeps making the same mistakes that so many dentists are making. No wonder dentists are so confused, because Dawson makes the same mistakes. Okay? I hope he doesn't think I am being disrespectful to him. He is up in heaven looking down. Okay? But really, honestly, okay? When you are making that kind of assumption, that's where it needs to touch. Where did the other criteria go? You cannot have both at the same time all the time. Sometimes you can have both, sometimes. But most of the times you can't have both. Okay? And I think it is really unfortunate that they keep forgetting this. Not only that. So here's the thing. So Dawson goes through this diagnostic wax up process by doing occlusal equilibration in the back first after he mounted it, right? He equilibrated it, and then now he is working on the anterior. Okay. What process did he go through to determine that the posterior occlusal equilibration vertical dimension that he ended up was the ideal vertical dimension? He doesn't talk about that at all. Just like so many other study clubs out there. I understand. I don't want to talk about vertical dimension unnecessarily, okay? Because it is not an easy concept. But what if you equilibrated occlusion on the posterior just purely for having simultaneous contact on all the posterior teeth in centric? Okay, hopefully at a costa-fossa relationship, not incline to incline contact. What if you're still too tall? So instead of having one tooth interference, what if you have 8 teeth interference, meaning all the posterior teeth are too tall? You will still be having problem. Okay? You will still be having problem. Now, it is not common that all 8 teeth will be in proper occlusal relationship and yet be too tall. It doesn't happen too often, but it is still something that happens often enough. Okay? So now, I'm not just opening up this can of worms and let the worms go all over the place. No, we already have the answer. It's just that we don't utilize it. Our ability to check envelope of function, our ability to check range, whether it's neutral zone, that's the word I was looking for. Okay? We do that by what? Doing what? Phonetic testing. And I think it is just so unfortunate that just about every dental education, phonetic testing is minimized. Now, to Dawson's credit, he does talk about that. He does talk about that. Okay? He does talk about that. Let me find it. I know we went through back and forth, back and forth. Page 174. Okay? Now, I would go through slightly different sequencing than what Dawson does. Okay. We're going to get to that. Okay? But so the whole point that I'm trying to say here is this. Dawson's book indeed has pretty much everything that I'm looking for. But reading the book in the sequence it's written, the way that the author has written, is confusing. And that's why people get lost. Okay? Now, here is an interesting thing. So I was trying to figure out how to deliver today's message, right? So, interesting thing is this. So on the chapter 17, the title of the chapter is Anterior Guidance in its Relationship to Smile Design. And then page 160, he talks about the first subtitle is The Importance of Anterior Guidance. I've read it like 3 times, just that part, okay? And guess what? There is no real definition of anterior guidance there. He already assumes you know what the definition is. Be my guest. Read that subsection of that chapter. He does not actually define anterior guidance. So I did what any one of you will do. I decided to look for it on the internet, right? So I am going to share. I know it's not much, just real simple. Okay. So I did a PubMed search real quick. And then there was this article back in 1978. Now, I'm sure this is part of my literature review that I did way back, but I don't have a PDF file, so I'm going to have to get a hold of it, and then I'll share this with you later on eventually. Okay. But, okay. The key to successful occlusal treatment. And so the abstract, let's just look at the abstract real quick. Okay. Because this is something that we all agree, we already know, but I wanted to just emphasize here. Abstract. The occlusion of anterior teeth is the key to developing and perpetuating an ideal occlusion. All right. I'm still listening. Okay. The anterior teeth protect the posterior teeth by discluding them in eccentric positions. And the posterior teeth protect the anterior teeth by receiving most of the forces of closure in centric position. And I said, yeah, I agree with that. But here is the thing. So in centric position, the forces in centric position are received by posterior teeth to protect the anterior teeth. So the front teeth, if the posterior teeth are protecting the front teeth, I think it's fair to say posterior teeth should touch more than the anterior teeth. Right? I think that's a reasonable assumption. So we need to make sure front teeth at least don't touch at the same magnitude as the posterior teeth. Now, how much less? The way that I was told in my PROS program was in initial contact, front teeth should not touch. In clenching, they should touch. When the posterior teeth have compressed into their PDL, they should touch. I go, okay, in some class 1 patients, I'm willing to do that. Okay. Now, they don't talk about, class 1 to 3, that's fine. We're going to talk about ideal occlusion, so we're going to stay with class 1. Okay. But then look at number 3. The anterior guidance is a result of both anterior tooth position and condylar border movements. Both factors must be considered in the creation of an anterior guidance. Now, what does condylar border movements? Okay, I'm gonna stop sharing this here. What does condylar border movement mean in the context of Dawson's book? That's your envelope of motion. Okay, so anterior guidance, some people will say condylar guidance or whatever. I don't really care how you want to describe it. The Bennett movement, whatever. Anterior guidance without regards to how the mandible moves is Wrong. So when you go to all these courses where they tell you you force steep anterior guidance so the mandible is forced to vertically open every time, is wrong. If that particular patient's condylar movements allow you to do that, great, you got lucky. But if the patient is a classic class 2, then that ain't gonna work. That's why you've been so confused. That's why anterior guidance is so confusing. That's why it has been unpredictable. Okay? And that's why I keep talking about this over and over. You know why I keep talking about this over and over? Because for every time I repeat this, you've heard 100 times more from other people all over in dentistry to tell you you want steep anterior guidance, you want steep anterior guidance, you want your front teeth to touch, you want the front teeth to force your mandible to open up vertically. You've heard that all your dental career. Okay? And so I many times I go to meetings, CDA or whatever, or PROS meetings, and I go in and sit in occlusion lectures just to see if there's something I've been missing out, or just to see how they deliver the message. Okay? And I'd like to claim that I really have not heard anybody who challenge anterior guidance the way that I am doing. They are like parrots. They are like broken records. They just keep saying the same thing over and over and over and over. Okay. So how much they touch is what really determines, not whether they touch or not. But so far, we've been brainwashed into saying they need to touch. They don't talk about how much. Okay. And how do you determine how much? Envelope of motion. You need to satisfy that requirement. Okay. There is, okay, I think I have, I'm looking at another thing that I had looked at before, and I think I have lost it. So I'm gonna go back. Here we go. So I guess we are all, I'm getting affected by AI. But anyway, so I was going to share one more thing with you. Mylene, yes, please.
So how do you evaluate if it's a healthy envelope of function?
Well,
Or like
number one
if it's a
requirement.
restricted envelope of function? Like you
So,
said it, like how much? Like how can you tell how much?
yeah. So the first requirement is there should be no phonetic interference in S sounds. Okay, that's number one. Number two, there should be no fremitus when the teeth come into contact. And the teeth come into contact in centric as well as in excursives. There should be no fremitus. So the patient may be class 2 relationship where in the front there is a clear 3 millimeter overjet. There is like a space between upper lingual and lower incisor, 3 millimeters of open space to satisfy the S sound. Okay. But then when they come in contact, there's fremitus. Let's say mobility, actually. How do you deal with that? Okay. If I am doing if I found the patient in that situation where there is mobility, infirmities, and all that. Okay? Okay. I need to make sure that when the patient goes through excursives, that it does not cause that mobility infirmities. They should touch, but not cause it. Which eventually means usually I need to shorten my lower incisors, or I need to carve out more of my upper lingual contour. So from a clinical perspective, those two are the usual guidelines besides trying to satisfy aesthetic expectations. Okay? And so this is why, like yesterday, I did lower six incisor veneers. I mean lower six veneers. Yeah, inside the canine to canine. Okay. And once I did the prep, and once I did the provisional, okay, how do I determine what my provisional length is going to be and where it's going to be? First, I need to make sure it's not touching centric. Okay, so I lowered it, I retroclined it to the point that I thought was reasonably not traumatizing to the upper front teeth. And then I looked at the aesthetics. I go, okay, there's still some room that I could maybe probably make a little shorter. But before I did that arbitrarily, I went ahead and have the patient do phonetic testing with me before I finished my provisional. So that's part of my provisional finishing. So then, yeah, I see here and there that's touching. So then I put my articulating film, IQ and have the patient go through protrusive. And then the approximate area where they were touching, I go ahead and I reduce that area more. Okay? Until I was reasonably happy that not only normal phonetics, that he was not touching, and when I have him go through protrusive, that the upper teeth do not feel overloaded by being displaced laterally. Only after that, I went ahead and I individualized the teeth with my disc and then made the incisal edges look like teeth in my provisional. And then after that, what did I do? I took an impression of my temporary. So my lab understands where to approximately position the incisal facial contour and incisal contour. Without that, what the lab will send me will be most of the times barely acceptable with significant compromise. Because I have to do all that adjustment in my final restoration. And it doesn't matter how much of a good job they did with zirconia or Emax, because by the time I touch my incisal edge, they don't look the same. Okay? So yesterday with that patient, I started at a little after 9 o'clock. I went on to 11:30. I mean, I had a couple of 5-minute walk away to take a look at hygiene patients. It only took me about, I don't know, my practice, I chat with them more than anything else. So let's say I was done with the prepping numb the patient, finish the prep and impression in about hour and a half, 2 hours. Okay? So I started 9, 10, 11, 11:30. I spent an entire hour. Yeah, that's about right. I spent an entire hour forming my provisional. Not because I didn't know how to take a, suck down model or whatever, or a putty thing. No, because I have to make sure I am happy with where that lower incisor is in relation to the upper. Okay? Do not go home and pray to the dental gods, hoping that they give you something you don't deserve, and that is perfect outcome when you haven't done the work. Wishful thinking. Prayers do not give you the clinical result that you're looking for. Preparation does. Not tooth preparation, but the preparation to prepare the case. Okay? The lab can only give you what you have guided the lab to. If I didn't give enough reduction, the lab cannot give me proper occlusion. It's always going to be too tall, right? And this is the part that 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 most dentists forget. And here's the next thing. This is something that I had to tell my at the other lab, another lab that I'm doing kind of like a rehab case again. Okay. And and so for them, I was doing the posterior now. The other case, I was doing posterior. And I gave them my posterior provisional teeth contours. And this patient is really, really finicky. It was actually, I knew it was going to be a tough case. He has not disappointed me. Very tough case. So what I've decided to do was from my chair side made provisional, upper and lower posteriors. So 8 teeth, 16 teeth, right? Okay. I decided to go to the one more step of making lab process temporary. Okay, because the patient is somewhat skeptical. He was breaking my temporaries right and left initially. Now his occlusion has been deprogrammed enough, and he's not breaking things. Things are not popping out. Okay, so I sent the case to the lab to do the lab provisional. I gave them the bite registration. Blah 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 blah. And then the lab guy says, "Oh, well, so Dr. Lee, we follow their the diagnostic wax up." And I go, "Wait, diagnostic wax up, yeah." I did do diagnostic wax up for the patient's benefit, and it was a freaking digital diagnostic wax up, right? So I said to the lab tech, "This guy is the head technician at the lab." I said, "Remember, I told you that was only to show off to the patient. That has zero resemblance of how it should be in the mouth. Because the diagnostic wax up did not go through phonetic testing. How long the incisal edge is, where the relationship is, the posterior cusp and all that, has absolutely no bearing on reality of the patient's mouth. And that's exactly what Dawson needs to remember. He does not emphasize that enough. He does talk about it a little bit, okay, how it needs to be customized in the patient's mouth. Okay? But to replicate your diagnostic wax up aesthetics, diagnostic wax up occlusion into your final restoration, because especially these days, if you give them digital scanning, it's so much easier for them that they take the diagnostic digital workup and transfer it into your preps. And that's not easy either. But with digital, at least it's doable, right? And they think they're doing you the favor by doing that. Okay? And I have to keep telling them, no, no, absolutely no. Okay? So this is the critical part that we have to remember. Okay, we have to remember that that when how should I put it? Real uh, to staying true to what we claim is what we need to do is not so easy. You know, um, you know, it's so, how should I put it, impressive that Dawson talks about the anatomy of the joints, anatomy of the muscles, the importance of the understanding of the bone, importance of understanding the nerve innervation and the mechanoreception. But if we're going to throw that all away as soon as we get to the teeth, what the hell? Okay. So it does take discipline, no doubt about it. No doubt about it. But that's how you make cases become predictable. Now, when you are doing your single tooth dentistry, okay, let's be honest, it's not easy. But here is how I do it. Let's say if I am working on number 8, okay, if I am doing a crown on number 8, all right, and I recognize, see, that's the first thing is this, you have to recognize what is not right in the patient's mouth. I recognize rest of the mouth is a mess. Okay, number 7, number 9, number 10 has primitives. They have chips on them. And I do phonetic testing and they're touching. Well, what am I going to do? First, I need to prep the patient. For the patient to understand that we're working in a not ideal scenario. It doesn't mean that I want the patient to feel bad for not doing a full mouth rehab. No, no, no. I'm just laying down, bringing down the patient's expectation. Frankly, if the patient is that situation, patient's expectation is primarily just aesthetic outcome anyway, and that's okay. Number two, I need to figure out how to achieve the aesthetic expectation the patient has while protecting my tooth. Number 8. So guess what? Number 8, I'm going to make sure it does not come in contact at all. Let rest of the mouth continue to break down. I don't think it's going to be considered a crime or sin for us by letting rest of the mouth stay where they are at. Okay? So that's how I try to weave through the realities of clinical dentistry. So now let's see if number 8 has been having a lot of incisal chips, and no matter how much composite you add, it keeps breaking. So I had a patient, another dentist has done repair work on number 8 and 9 for many, many times. It keeps chipping off, chipping off. And when I looked at the patient's mouth, and the patient was upset, the front teeth chipped again. I looked at it, and I give the other dentist credit. He got about 80% right. The front teeth were not in contact in centric, and even in phonetics, they were not touching. And they looked pretty decent. How did he do that? The patient was almost edge to edge. He built out the anterior bulk with basically doing a chair-side composite veneer, okay, so that he can give front teeth the freedom in centric. And in protrusive, it's uniformly touching instead of just 8 and 9. So I'd say he did actually pretty good. Guess what he forgot? The dentist forgot that the patient was wearing a night guard, because the prior dentist, the one before, said, well, you're breaking down your teeth so much you need a night guard. So the patient has been wearing a night guard all this time. Well, you do the incisal edge build out or facial build out, or even if you just do the repair of a chipped tooth. If the patient has Invisalign as a night guard, not even just a night guard, an Invisalign aligner as a night guard, you are begging the Invisalign to break off that composite. Okay? Yeah. So the patient says, yeah, I wear a night guard. I go, night guard, huh? I see. Did you bring it? No, no, I didn't think it was important. Okay. So I said, is it a soft night guard or a hard night guard? And the patient, I think it's hard. I go, it's hard. I go, who made it for you? This is the series of my questions because I don't want to be accusatory. I don't want to tell the patient, you dumbass. I don't want to say that, right? So, who made it for you? And then the patient says, oh, my orthodontist made it for me. Oh, really? Yeah, that was like my Invisalign. My orthodontist said I can wear that at the end as my night guard. So there's my answer. You know, a lot of times what the patients tell me is what gives me half the diagnosis. But not only that, but prior to that, because I had a chance to read the history of the dentist whose most recent work got chipped off in number 8. Guess what? He had also done direct restoration, composite filling. I think it was like MO or whatever, a number 15 of the same patient. Again, there was no mention or discussion about Invisalign night guard. Even if you only do occlusal filling on number 15, there's a very good chance your Invisalign is not going to fit the same way. If it's a hard acrylic night guard, you have the chance to do some adjustment, as I tell everybody to do so. But Invisalign, no, 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 you don't have a chance. So, so going into your clinical practice, these are the things that you need to hopefully take the lessons that we learn from Dawson's book into your clinical dentistry. That we have to become better at diagnosis, not just do what we do as a clinical work, but figure out what's going to work and what's not going to work. I had to tell my patient, it's not going to work. I said, the other dentist is tech. I had to kind of like make sure the patient doesn't get too mad at the other dentist. So I go, the other patient is technically actually very good. It's just that you and the other dentist failed to communicate that you wear a night guard, and the night guard does not tolerate this kind of shape changing. Okay. And I didn't want to get involved. So I said, go back to the other dentist. I'm sure the other dentist can now do a much better job. Just make sure you tell the other dentist, show him your Invisalign, and be fully expecting the other dentist to make you a new night guard. You know? So so that's how I hope our lessons that we learn from our these sessions can translate into your real-time benefit of single tooth dentistry, even if we're not doing whole teeth. You know, talk about posterior interference. Having an Invisalign is a guaranteed posterior interference. Assuming somebody had reasonably good occlusion, you wrap around all the teeth surfaces with, I don't know, 2 millimeter thickness or 1 millimeter thickness acrylic. How do you expect occlusion to continue to be stable? No, it's not going to do that. You know, so it's to me, uh, orthodontists were bad to begin with to pay attention to occlusion. But Invisalign has completely thrown that out the window. This past week, I had to have a conversation with an orthodontist regarding a mutual patient, and this mutual patient has, in my opinion, His biggest problem is he's maybe in his 40s, early 50s, late 40s. To me, his biggest challenge is the anterior teeth contacting too much, okay, which is, you know, which happens a lot, right? And then I did tell, I'm the one, I did tell him that we need to try to improve that. And my answer to him was, let's just do a posterior rehab where I can make your teeth a little taller in the back, give anterior teeth some freedom, because his anterior teeth were already proclined quite a bit in the upper front. And he's already got some class 3 tendency. And when I tested him for phonetic testing, his teeth were not in interference anywhere. In fact, I thought that he had some space for me to open him up. That's why I said that. So what does he do? Just like a well-informed consumer these days, he goes to see the orthodontist that his kids went to. Okay, and the orthodontist sends me a report saying, "Oh, patient is in crossbite on the left side." And I'm going to try to correct that. Basically, he makes no mention about anterior teeth except to say the anterior teeth has class 2 tendencies with 5 millimeter overjet. Well, but guess what? How does the orthodontist measure overjet? Their definition of overjet is different from restorative dentistry definition of overjet. Restorative dentistry overjet is the actual space between the upper front teeth lingual aspect and lower front teeth incisor aspect or facial aspect, and whatever the space there is. That's our definition of overjet, the actual space of the contact points. Orthodontic definition of overjet is where you have the facial plane of the upper front teeth to the facial plane of the lower front teeth and how much space there is, the measurement. So it gives you no indication whatsoever whether the front teeth are touching or not. Okay. To me, it is just absolutely ludicrous for them to use that definition. You know, that should not be even be called part of occlusal definition of occlusal examination. That's just purely aesthetic examination. Anyway, there's no mention of it. And this guy, I'm sure he's by now he's got a few years of experience. You know, and I don't introduce myself as a prosthodontist. I say, hey, I'm the one who is taking care of this patient, and I understand, he went to see you for orthodontic consultation. He goes, oh yeah, and then he goes, what can I do for you? Of all the years that I've had consultations over the phone, discussions with other specialties, including even MDs, I don't think I had anybody who was that rude, you know. So I had to just kind of hold my tongue back and I say, hey, I just wanted to make sure that you and I are seeing the same thing. You talk about the crossbite on the left side. I frankly don't really see that as a deal breaker. What I really see as a problem here is that his front teeth are getting traumatized from getting too much of a anterior contact in centric stop. And your definition of 5 millimeter overjet does not convey that. What I'm looking for is whether you retrocline the lower anterior teeth or whether you intrude them or however you do. What I'm hoping that you're gonna, when you go through this trouble of doing this case, I'm hoping that you're gonna give me some anterior freedom that the front teeth are not gonna touch. And only then he kind of like, oh, okay. And then he was trying to like still like roll over me with a steamroller, and I said, you know what? I had to kind of like say, I, yeah, I understand you as an orthodontist what you're trying to do, but as a prosthodontist with over 30 years of experience, this is what I need. And only then, only when after I identified myself as a prosthodontist, he was willing to sort of like try to speak my language. So I could totally see him having that attitude towards GP, saying, "What can I do for you? What do you know that I don't know?" And it was just so disappointing, so disappointing. It's an orthodontic group with three orthodontists, large orthodontic group in West LA. And I can tell you, I am never, well, first of all, the patient did not get referred by me there, right? I am never referring a patient to that office. I am used to my orthodontist calling me and saying, "Hey, Tom, I think I am ready to finish the case. Can you go ahead and do your examination and phonetic testing to tell me if I gave you enough anterior overjet?" Whether they are able to truly achieve that or not, I want them to at least talk about it. I want them to at least give me a lip service. There's a world of difference between somebody who tried but wasn't able to achieve it versus somebody who didn't even try, in fact, who completely ignored it. You know? And as restorative dentists, it is our responsibility to find those orthodontists and and steer our patients to those orthodontists. Before I send a new patient to an orthodontist, I make sure I sit down with them and I tell them what it is that my expectation, you know? And it's not easy, to be honest. It's not easy. I understand. Okay. So, I digress there. But let's take a look at something here. Take a look. This is where a lot of mistakes are made. This is why. So we'll take a look at page 153. Okay, take a look at page 153. Take a look at that diagnostic cast, figure 16-1. You look at the anterior relationship. So the patient has what can be described as class 2, division 1, whatever. Okay. Front teeth are not in contact. Lower front teeth looks like has had reasonable amount of breakdown, right? And then when you go to page 156, okay, that was on the top picture, okay, top picture. So he's talking about posterior teeth, but just take a look at the front teeth, okay? You see the same picture. Upper front teeth are worn down, lower front teeth are worn down. There's actually space in centric relation. So the way that Dawson does the buildup, okay, of the front teeth, take a look at the diagnostic wax up on page 154, bottom picture, the bottom picture. So after he's done diagnostic wax up, I'm sorry, occlusal equilibration. So he mounts it in centric relation. He marks where the premature contacts are. He does occlusal equilibration. And then he does the buildup of the lower anterior first. Right? You see the sequence. Take a look at where that wax up is finished to. To go to page 155, the top picture. He indeed makes it so that the lower anterior teeth are touching plane number 1 on upper incisor teeth lingual contour. And then onto that, he builds upper front teeth. So he's consistent, at least in his method. But I am here to tell you, absolutely wrong. Okay? Now, if you were to tell me, Dr. Lee, I did this to make it look good, this is going to be a starting point, and the actual location and the shape of the lower front teeth will be determined at the time of provisional, then that's a correct answer. I don't have any problem with that. That's indeed what I do with my cases when I do my digital diagnostic workup these days. Okay? But do not make the mistake of doing the wax up like rest of the page 155. So now he finishes the upper front and he articulates them. As being dentist, you look at the last picture on 155, you know that the lower front teeth and upper front teeth are touching and when they are put together like that. Do not assume that is what we're gonna try to deliver for the patient as a final restoration. So in page 157, Dawson gives me this little way out. He says, on the left-hand column, the little box, it says, you cannot trust a diagnostic wax-up regardless of how beautifully it is done. It is the rare diagnostic wax-up that cannot be improved in the mouth. I'll take it. The matrix of functional anatomy can only be determined in the mouth. I'm going to say I would have probably put a comma instead of period there and with type of really big bold as determined or guided by range of motion. Okay, but those little sentences do not grab the reader's attention when people are reading this book. Okay, so he goes on the matrix of functional anatomy. Okay, the next paragraph. Okay, so I think I'll just read the whole paragraph because I think it does sort of set up the stage. For many years and thousands of anterior restorations, I studiously observed the functional relationship that matched up with the contours and positioning of anterior teeth. As a restorative dentist, I had many opportunities to alter incisal edge position and anterior guidance and then observe the effects. Working with provisional restorations, it is possible to make instant changes and then objectively analyze the effect on the lips, phonetics, comfort, and the appearance of the smile. I wholeheartedly agree every aspect of the paragraph. This is why your ability to make good provisional and work out all the kinks in the provisional is so critical. You are setting yourself up for the success when you do that with provisional. We're all watching World Cup these days, right? The provisional is that perfect corner kick that lands onto the head of your teammate who's going to head it in, or lands into right in front of your teammate's right foot or left foot. They're going to kick it and get it into the goal. The provisional is that perfect setup kick. Okay? Mylene, yes.
I think having said that, there should be like in the process of the workflow, that step as a formality would be a functional try-in.
Functional trying. What do you mean by functional trying?
I know, I'm like coming up with my own terminology. So yeah, that's what I'm suggesting. Like there should be an additional step or a formal step in the process, and one of the formal steps should be a functional try-in, which would be the provisional. I mean,
Oh,
I'm suggesting they should come up with a new terminology
oh,
and
I
be
see, I
like,
see, I see, I see. Yeah,
in
yeah,
the
yeah, yeah.
Dawson should put in as a formality, one of the steps should be a functional try-in, like meaning like you're checking your provisional
Right.
in the
Well,
mouth.
he uses that word functional anatomy, functional trying, yes. And I can tell you that with the digital technology, we are gonna be getting closer and closer to. So recently I did another case where I was doing upper six posteriors, two molars and second bicuspid because I didn't want to prep on the first bicuspid. First bicuspid, I just did it as a composite to create a little bit better occlusal relationship. Again, chair side provisional first. I worked it out for over a few weeks because this patient is a dentist, right? Worked it out for a few weeks. Patient is reasonably happy with how the occlusion has worked out. Okay. What do? I scan that. Okay. I scan that anatomy, the bite relationship, and then I went to one more stage, provisional. I scanned his preps, and then I overlaid it onto my prep, my scanned provisional contour, overlaid it onto my prep, okay? And I followed my new crown anatomy to more or less follow that dimension. And then I created more defined cusp because to be honest with you, when I'm doing a chair side in the mouth, it's hard to have a defined cusp, right? So I made a more defined cusp and the material that's going to be milled out of my milling machine is going to be stronger. So it's going to hold up that anatomy much better. So I am doing that one more step on that. And then what I learned from that will be scanned again into my formation of my final restoration. So with the digital dentistry, we are getting closer to that, where making of the provisional restoration helps you in that direction that you are exactly thinking, Dr. Mylene. The one of the reasons why I recognized digital dentistry was something that I had to learn and master a few years ago was because when the traditional PFM and gold, I was relying on the technician who does not have chairside experience. And to them, everything was mounted on an articulator, and that was it. Whether it was a good articulator, bad articulator, but it was still on an articulator. And no matter how much provisional I gave them, copy, I was still at their mercy to spend the time to follow through on the contour guided by the provisionals. But now with the digital dentistry, I can have some control over that because I can have my designer prove it to me by having that overlay over with my provisional onto the new crown design. Okay, so Mylene, I hope that sort of it kind of shows you how exciting restorative dentistry can be. And I think I told you folks that you know so my initial learning point about digital dentistry a few years ago was confirming every design that my technician was doing. After that, then I saw how my provisional can be overlaid onto it and they can copy that, especially in the front. Okay, so I did that. Now what I'm doing is even in the posterior, I'm doing that, and I am, all the funny occlusal relationships that ends up becoming because of how I look at occlusion. Um, because I'm doing my own design and milling, I have much better control over that now in my office. I don't do as much occlusal adjustment when things go well as nearly as what I used to do before. Even after when I would approve the digital design my lab tech gives me, many times I had to do a decent amount of adjustment. Okay. Um, but now, because I'm the one who's designing it, now it's not a way to make more money because your time is better spent doing the clinical work and let the lab tech or your assistant do the design, but they just don't understand, And I think if you have a large enough office and where you can have a talented assistant that you can train, that could probably save you a lot of time. And especially if you're in a sort of like a larger practice. But for me, I enjoy my practice, the low volume practice, and my occlusion is becoming more and more predictable the way that I design it. And so with the digital dentistry, and that's from taking the lessons of the exact same thing that you talked about. That is the functional triad, functional matrix of the patient's anatomy that I worked out with the provisional. So, looking at this diagram on number 16-2, the figure, okay? You know, yes, that aspect of number one, contact point, is critical, but not the way that Dawson envisioned it. Dawson envisions it as that's the spot where you have to have a contact eccentric. No. In fact, to be honest with you, number 1, 5, 4, the whole plane needs to function as one unit to give me the allowance for my range of motion, my envelope of motion. The entire contour is what's critical. Okay? So let's get into page 17, anterior guidance. Before we do that, why don't we take a 15-minute break time? It's 10:45, it just became. Why don't we take a little coffee break, potty break, and regroup again at 11 o'clock, and then we can hopefully finish up that anterior guidance section. Okay? Sounds good? Thank you. So here's Dawson himself saying it. The upfront, in your face, chapter 17, page 159. Anterior guidance and its relationship to smile design. Principle. Anterior guidance must be in harmony with the envelope of function. He himself is saying that. Okay? So that's what we have to remember. Now, what I wanted to do earlier was what I did was I looked at Gemini, Google, and I looked at what Google will say about anterior guidance. Okay, so uh, I looked at anterior guidance in the Google and Gemini. This is, you can see this, right? So this is what it says. Anterior guidance is the dynamic relationship of the front teeth that dictates how the lower jaw moves. See, I wish they would give us definition like this in Dawson's book. It doesn't actually do that. That's why I kept looking. Okay. When you slide your jaw forward or side to side, the front teeth interact to separate the back teeth, protecting them from damaging off-center forces. Okay. How it works, mechanism. When the jaw moves forward, protrusion or sideways, lateral excursion, the lower incisors and canines slide along the lingual or back surfaces, the upper teeth. The protection, this sliding action immediately discludes separating the posterior teeth because back teeth are structurally built to handle straight vertical pressure but are highly susceptible to damage lateral stress. Separating them is essential. Okay. The three guiding factors. Anterior guidance relies on three harmonious elements: the position angle of the upper front teeth, the position length of the lower front teeth, and the angle of the mandibular joint sockets. Okay, the temporomandibular joint sockets means that again, the range of motion. Okay, now this is where you and I know that Gemini is trying a little too hard. Types of anterior guidance system: the canine guidance and group function. Well, the group function is not anterior guidance, but this is why we can't take Gemini, every word that they say, right? Okay. But clinical significance, excessive wear, it prevents that. Tooth fracture, hopefully it prevents that. Okay. TMJ pain, hopefully it prevents that. But all of that is only if they are in harmony. Okay? All of them are only if they're in harmony. Okay? So, so now if you go back here, okay, this is why another thing that I always try to emphasize to people. Okay? The primary function of anterior guidance is to protect the posterior teeth, prevent the posterior teeth from touching each other in excursives, protrusive and excursives. Well, we can minimize that by controlling the posterior teeth anatomy as well. Okay? People only think that anterior teeth are the only ways we can control the posterior teeth contacts in excursive movements. That is not true. Controlling the posterior teeth anatomy also is a significant part of this. Okay, so keep that in mind as we are going through this anterior guidance section. Okay. So, and eventually we're going to come to that point when we talk about the occlusion, about the posterior teeth. Okay. So, um, but the picture that we're perpetually reminded of is figure 17-1, as I showed you earlier, where you have the posterior teeth that are represented by dots and anterior teeth that are represented by lines. And where the lines come together is assumed to be the anterior contact point. Okay? If they are not touching at anterior contact point, then the lines would not be connected. If you actually had a long centric where they're not in contact, okay, then what you will see in the anterior will be one line going towards the front, anterior. It does not connect to the lateral contact. It comes and the lateral contact, there will be a void. There will be an empty space. That's your centric freedom. Okay? And that is probably more applicable to most people rather than this need come to the dot point, apex point. Okay. And you know, we're killing this over and over so many times, so I really don't want to repeat myself too much. But let's take a look at page 162 and 163. Okay. And he's saying on 162 at the last paragraph on the left-hand column, this is where again he misleads us. I'm sure not intentionally. The contour of the centric relation context on the upper anterior teeth must be shaped to form a definitive stop for the cingulum whenever that can be achieved. Any contacting contour that does not prevent further eruption of the lower teeth will be unstable. A high percentage of anterior wear and instability problems are the result of improper centric relation stops. So what he's saying is that centric relation in CR, the front teeth have to stop. The front teeth have to contact. Again, he falls back to his mechanical side only. He does not, he forgets the envelope of motion thing. If you go through the envelope of motion and if you determine the anterior teeth not to be in contact because envelope of motion dictates your lower front teeth to be shorter or more retroclined, wherever it's at, that has to be respected. You cannot then make it arbitrarily taller and have it contact the front teeth at that red line with that plane where you want it to. Number one, if it is touching indeed in that angulation, and if the patient is clenching, your upper teeth are getting displaced out. And that's no good. If you truly believed in this, then what you need to do is to make your upper front. If you follow my thinking, you take a look at my camera. What it needs to do is come down, and the contact point should be horizontal, and the incisal line coming down further. And instead of like a 30-degree, 45-degree, it needs to be perpendicular, just like posterior cusp fossa. If you truly want it to be a vertical stop, that's the way it should be. But they're going to say, well, that doesn't look right. I know it doesn't look right. But if you're truly going to insist that they have to be a vertical stop in the incisal point, then it needs to be like that. Otherwise, it's pushing the upper front teeth out. So the irony of what these anterior guidance people are claiming needs to be pointed out so that we can tell everybody this is wrong. Now, he says on page 163, when you are touching too much front, where basically the upper teeth and lower teeth are touching just at a vertical line, or where you see this often too, where the upper front teeth are not concave enough, where the lower incisor bumps into the upper front too much and creates that where the excessive occlusal wear, incisal wear that you see on page 163, they are just as bad. Maybe not as bad, but essentially same idea. Okay. So what is the difference? It's the degree to which they're touching. You're absolutely right. So Dawson is sort of, he's sort of around there, but he's just not able to articulate it more definitively. Okay. So So when you look at page 164, okay, figure 13, I'm sorry, 17-3. He says, visualize the mandible in an inverted tripod. The posterior determinants, the condyles, have a subtle, stable uppermost stop in centric relation at their apex of force position. At this position, the condyle disc assemblies are stopped by bone. Wrong, ligament. I'm sorry, the disc. Okay, but that's all right. Close enough. So they cannot move any higher, even under firm compression by the elevator muscles. The anterior determinants, the anterior teeth, also have a stable stopping point if the context eccentric relation are properly contoured to solidly stop jaw posture. How can you say that's a solid stop when you're looking at it and it's an inclined contact? Upper lingual is inclined contact. What this picture should say actually is you got two condyles and posterior teeth that provide firm vertical stop. If you have adequate number of posterior teeth that are calibrated, so your right side posterior teeth and your left side posterior teeth are in harmony with the condyles, that will give you the stability that we're looking for, not the front teeth, not the front teeth. This drawing almost leads you into believing that the front teeth vertical stop is more important than posterior teeth vertical stop. Indeed, that is exactly what many people in anterior guidance people say. But that is so wrong. Posterior teeth vertical stop is much, much more critical. Now, I can say much more difficult to calibrate, yes. But just because something is difficult does not mean that that's not what it is. Okay? So I'd like to point out to you, you know, so to me, Dawson uh, insisting that anterior teeth provide vertical stop is the same mistake that he makes when he says in CR it's a bone-to-bone relationship. And these notions come out of them studying years with articulators. Because articulator, what you see is upper element and lower element of the condyle, which are really bone elements that are representing. But in reality, in healthy joint, and Dawson claims we have to have healthy joint first. In healthy joint, you're supposed to have what? The disc between the upper bone and the lower bone. And the very nature of the compressibility and slight mobility of the disc makes your bone-to-bone relationship slightly variable. Your CR is not a pinpoint dot. It's slightly variable from day to day, number one. Number two, instead of the anterior teeth providing vertical stop, which by looking at the incline, they are not stable, you need to have difficult to achieve but still achievable bilateral posterior vertical stop. That is what provides stable occlusion. Now, he says if the front teeth don't touch, they're going to continue to erupt. That's not true, at least not always, because we see plenty of people with anterior open bite. We should never have any anterior open bite if teeth continue to erupt. Okay? So, so that's something that we need to, also keep in mind on that. I don't want to digress out too much here. So he goes through all these steps of, so he talks about decision one as decision, he talks about decision two in page 164. Where is decision one? Decision one started in the previous chapter. Okay, just wanted to make sure you understand, okay? In the previous chapter in page 157. Okay, when he pointed out to you that plane number one is the most important part, and or you can say 162. Okay, wherever they come in contact in centric stop, he's saying that's the starting point of upper lingual contour and the incisal guide, anterior guidance, and then that he follows through the upper lip support by defining the plane number two. Okay, after determining plane number one. Well, plane number two, in my opinion, is probably not how I will define it first. Okay, let's just go through. After that is decision number three. And then he talks about, when he's talking about decision number three, and on page 166, okay, he starts to talk figure 17-8, 17-7, and 17-8. He talks about how the upper teeth incisal edge relationship is with the lower lip. Okay? And we go through all this step-by-step thing here. And I will just say, let's go to, I think it's a little exhausting in this chapter, but let's go to 168. I'm going to just jump over to 168. Let's take a look at the 5 steps in harmony. So number one, step one, establish coordinated centric relation stops on all anterior teeth. So he really does believe that. He wants to have that's upper anterior teeth. He thinks that the upper anterior teeth should have anterior stop. But if you look at it carefully, it's almost like a vertical stop that I told you, right? It's almost like a flat stop, 90 degrees, in some of them at least. Okay? And then, let me see, step two, extend centric stops forward at same vertical dimension to include light closure from the postural rest position. What does that mean? He's actually telling you that it's okay to have a little bit of a long centric, meaning your jaw can go slightly forward without immediately excluding. That's what he's trying to say. He wants to have the cake and eat it too. Okay, fine. That's fine. Some people, I mean, in some cases, yes, this can happen. This can work. Okay? And then step three, determine the incisal edge position. Okay? Location of the incisal edge in page 169 on the right side, right-hand column, first paragraph after step three. Determine the incisal edge position. Location of the incisal edge is second in importance only to centric relation holding context. If the anterior teeth are stable and no contour changes are needed, the incisal edge should be maintained. If the incisal edge are to be altered restoratively, the changes should always be determined in provisional restoration first and then copied in final form only after the patient has approved the comfort and appearance. Step 4, establish group function in straight protrusion. E means group function in all the anterior teeth. Okay. And number 5, establish ideal anterior stress distribution in lateral excursive, so lateral excursive. But take a look at, by the time you get to figure 17-14, I mean, he's done a lot of grinding on the upper front. Okay. Now, I'm not suggesting that's wrong. I'm not suggesting, because I don't know about this particular patient's, movements, anatomic makeup. Okay. But what I want to emphasize, is that the the teeth relationship is not necessarily ideal to begin with. That you do end up grinding a lot, and so you have to decide which cases you want to really dive into with this kind of thing. Okay. Now, before we get back to the aesthetic part of starting page 171, okay, I am going to invite you to jump over and take a look at page 174. Okay. And he essentially kind of goes through step by step again in a quick review, right? And if you would care to entertain, the way that I look at it is step 6. Refine incisal edge position using F and V sounds. Ooh, look at that. That sounds almost like Tom Lee. Okay. Start out with fricative sounds. F and V sound. Determinations must be made with gentle, soft-spoken sounds. Make sure incisal plane contacts inner vermilion border during gentle speech. F, F, F. That is actually your number 1. That is number 1. Okay? I wanted to emphasize that's number 1. Now, it does not mean that, remember what I said about that. And what I mean by that is, so number 1 and 2, the step 5, you need to think about it back and forth. What I mean by that is, determine incisal edge length. This relationship is important for phonetics of the F and V sounds, as well as for best aesthetics. So the upper front teeth position is determined by F and V sound and what the patient's aesthetic expectation is. Because the upper front teeth in itself does not have to worry about the lower teeth yet. Because the ultimate aesthetics is the upper front. If you want to achieve things aesthetically oriented, you need to keep upper front teeth position as a starting point. So make sure you and the patient are happy with the upper front teeth, the positioning, the length, rotation, whatever way you want to characterize it, okay? Make sure you're happy with that first. Now, if you're not in a position to alter that, because like my patient that I shared with you earlier yesterday, my number 22 to 27 veneer prep, I'm not going to change the upper front. Okay? I know that they're a little bit on the long side, but if I talk to the patient about that, he's going to flip. Okay? So I'm going to leave it alone. But now the game is heightened a little bit because now I have to make lower front teeth still be in harmony with the upper front teeth. Okay? But that's with, so I accepted his upper front teeth relation, upper teeth position, size, and everything, length and everything, knowing it is not ideal, but I have to accommodate that with my lower teeth. Okay? So number 1 and 2 are dealing with upper front. Okay? Now, part of number 1 and 2 with dealing with aesthetics is step 3 in Dawson. That is lip support. So when you are dealing with these teeth, okay, when you're dealing with the teeth in the upper, sometimes just incisal edge position is not everything. We have to actually bulk out the facial aspect, or in denture, bulk out the flange, or whatever we have to do to get the desired lip support relationship that we want. Upper lip. So the F and V sound is relationship to the lower lip. But now we have to decide the relationship to the upper lip. And that has to do with the facial plane of the incisal. So sometimes I have to deliberately make them fat to support the lip. Okay? So all of that is, you can do 1, 2, 3, doesn't matter. But the very starting point is the F and V sound. And from there, I can deviate based on the patient's desired aesthetic outcome. Okay? You can still make it longer. You can make it a little shorter. You can make it fatter by coming out, or you can make it go in more because patient doesn't like buck teeth. Whatever it is. But you choose the upper front teeth relationship or positioning and the condition of them deliberately. Okay? After that is done, then you look at step 9 as Dawson wrote it. But to me, that's the next step, and that is the S sound. Establishing S sound. That's number 4. Okay? So step 6 is number 1. Step 5 is number 2. Step 3 is number 3. All of them deal with upper front teeth. Now we're dealing with lower front teeth by evaluating for S sounds. Okay. Now, step 9 and step 8 has to go back and forth, back and forth. And what I mean by that is, before you do S sound, if you are doing the provisional, okay, what you need to do is, as I told you earlier about what I did with my veneer case, temporary, I start out with something that's probably a little too tall in the lower front. Initially, before I do any phonetic testing, I want to make sure that it's not too long, the lower incisor. I want to make sure that when they are touching, the posterior teeth are touching. So I'm willing to adjust it without doing any phonetic testing until my front teeth are touching in centric, but not too much. Just like what Dawson said. I don't mind not as the end point, but as a starting point, my front teeth barely touch when my posterior teeth are in full contact. And I check for my fremitus, make sure my upper front teeth are not getting pushed out. Okay. Once I get to that point, now I do phonetic testing. And if I do phonetic testing, when I do phonetic testing, despite the fact that upper front teeth and the lower front teeth barely touched, but during phonetic testing, if they're touching more, then I need to reduce more. Okay. So using that S sound and using the envelope of motion, okay, and then making sure my teeth don't get traumatized, as evidenced by fremitus upon occlusion. I determine the position and the length contour of my lower anterior teeth as it relates to the upper anterior teeth. Sometimes I may need to make upper anterior teeth lingual aspect much more concave because I have limitation to how much I can reduce on the lower. Or sometimes I do exclusively on my lower because I've got room and I don't want to compromise the upper. Okay? Now, in some situations, I had another case recently where I am working on upper crowns, number 8 and 9. And I was contemplating, even though the patient had number 9 full coverage crown that had the lingual aspect broke off because they were hitting too much. So my initial thinking was, maybe I need to make this into a veneer, even though it was already a crown. And you go like, what? And the simple reason is because if somebody's front teeth are touching too much, forget about the fact that patient had previous crown. Just forget. Let's just say if they were teeth to teeth. If they're touching too much, and I am trying to give them some space for envelope of motion space, sometimes if I do enough grinding on the lingual aspect of the upper front teeth, I may not have anything left. Because after I do the grinding to make sure there is freedom, and then I have to reduce at least 1 millimeter more for my restoration thickness. So let's say if I had my upper front teeth appear like the teeth in page 170. Let's go back. After Dawson was done with occlusal equilibration, and my upper front teeth looked like that. And let's say I wanted to give this patient good-looking teeth. Do I want to do crowns on these teeth and wrap around more and then reduce another minimum millimeter, if not 2 millimeters of those upper anterior teeth lingual? No, we don't want that. So in situations like that, so if this is what I had, if the picture of 17-14 is what I had with my patient at chair, and my patient is expecting Hollywood smile of the front teeth, what I would be doing is I would be doing veneers on those teeth. I would not be doing crowns. Because then if I do veneers, I don't have to grind on the lingual aspect as much. Because I don't have to wrap around it with restorative material. And when I'm trying to wrap around it with restorative material, sometimes I end up grinding way too much. And my tooth will become so thin, and I can have pulpal damage, and the tooth just structurally becomes too thin. I hope that makes sense to you. Okay. So sometimes veneer is actually much more preferred material for long-term occlusal stability. Okay. So I hope you see my logic there. Okay. Okay. So then after we are done with, I'm back to page 174, 175. After we are done with anterior teeth position, lower front, and then the contour, and the phonetic testing with the S sound. Okay. Then we go to, it's kind of an extension of that S sound again. Number 6. The step 7 is what I would consider to be 6. now adjust for long centric if needed, meaning make sure there is no fremitus, make sure in phonetically there is no problem. Okay, those are all the things that we need to make sure. Once you do all that, in my opinion, step 10, evaluate for cingulum contour, okay, is not really that significant. Okay. So, key point, this is, if you were to live true to the letters, key point here is the critical part that we all need to remember. Okay, for optimal stability, comfort, and function, the anterior teeth must be in harmony with neutral zone, in harmony with the lips, in harmony with phonetics, in harmony with centric relation, in harmony with the envelope of function. Okay, this results in teeth position and contours that are in harmony with the matrix of functional anatomy that also produces the most natural aesthetics. Yes. Okay. So that's what we have to achieve for. But nowhere does it here in the key point does he actually repeat lower central relations. No lower central incisor should touch upper central incisor on the lingual contour. No. Okay. So this is why Dawson's book is confusing people, because different parts of the book gives you different messages, and those messages can be confusing. Yes, Mylene?
Yes, I noticed that like you were just rearranging like order of importance, and I'm just wondering where do you fit in steps 1 and 2 again?
Step 1 and 2, as Dawson wrote,
Mm-hmm.
to be honest with you, nowhere.
Mm.
That's secondary to me doing everything else. And wherever the incisal edge ends up, let it be. Excellent question, because I guess, yes, you're right. I didn't talk about that. Yeah. So when you do that, many times your front teeth do not come in contact in centric stop. Many times. And that's where people get confused, because Dawson repeated so many times, they have to be in stop. They have to contact. And I say no. And then go back to Dawson's key points. Where does he say they need to be in contact? You know? Okay. So just kind of keep that in mind. Okay. Um, I think it's important that okay. I want to it's I know the confusion. I understand where the confusion is coming from. Mari, you just texted me. Feel free to speak up, Ellie. I mean, Mari, because this is a small group now. Uh, tell me what you want to say. I don't quite understand.
So last time he was looking for a definition for the anterior guidance in the
Uh,
book. He said, I would say the key
oh,
point.
I see what you mean. So we can look at this as a definition of anterior guidance. I see. Yes, but this is quite different than what most people expect. You're exactly right. Okay. And this is exactly what I mean when I give my lectures, where I tell everybody anterior guidance is overrated. Anterior guidance is not the endpoint as you understand it. And that's where you make the mistake. Okay. So when he talks about the lower incisors, it's somewhat of a continuation of this conversation, okay? But before we get to that, I wanted to emphasize, so when we talk about the aesthetics, let's now roll back to page 172. Okay, 172. And yes, there are certain aesthetic visual cues that do make these teeth look better and this and that. Okay. Um, Studying this page, I think will be helpful for you. Um, to be honest, I'm not really big on aesthetic aspect, not because I don't care, but I don't think I'm as good as other guys who talk about aesthetics because, my idea of aesthetics is very wide ranging, you know. So it's something that beauty is in the eye of the beholder. You can look at many different people's ideas and incorporate that into your aesthetic expectations. What I do want to say is this, and this is why I had this page marked for myself for you. Looking at page 173, figure 17-16, that where he is demonstrating the use of the separating disc, diamond separating disc. If you want to become good at chairside provisionals, you have to learn how to use the disc. Okay? And if you're not good at it yet, that's okay. I know most of you didn't have enough training experience with the disc, but I will say you need to practice that. Because without that, neither you nor patient will be happy with the provisionals in the front, especially when it's multiple units. So that's what I wanted to emphasize here. Okay. And I think what I want to do is, today being a smaller group, I think we did have the benefit of going into a lot of different things, or more in depth rather. I want to save the lower anterior teeth thing for the next session. And the reason is because I know that I'm gonna, even though I'll have the what you might call it, recording for people. But I hope that more people will be able to join in and we can have more in real person discussion, okay? Because, all of the concepts that we're going to be talking about going forward, so one leads to another and leads to another and so forth. So I wanted to stop here for today, okay? I think I think we got a pretty good discussion about how I feel about anterior guidance and how I arrive at where I need to be looking at. What I wanted to talk to you about was before the other doctors signed off today, when they signed on a little bit earlier, I was talking to them about how we can improve our sessions here. And one topic was that there's a limitation to, because especially Christine is more younger practitioner, how to translate this discussion into their clinical dentistry. What I was hoping for was that somewhere along the way, next month or the few more months as we're going through the book, sometime next year, as we to make it coincide when we finish this book, I am thinking, I don't know how many people can participate, but I am thinking that we can have a group session in person where I think where it's going to be most helpful is going to be where I fit everybody their splint night guard. so you have a baseline as to what it needs to be. It helps, obviously, if I help you make your own, I mean, for you to deliver something, man, but that requires a lot of time. But if everybody made one night guard for themselves, and then to have for me to deliver it for them so they can feel it, the difference, both the fitting and occlusion, I think that will be helpful. I'm still debating whether it should be at group session will be easier. But I am curious how your perspective is. Sometime next year, what I was hoping to do was maybe people can make I don't expect everybody to be all at the same time because that's going to be kind of hard. But what I'm thinking is maybe I can accommodate people coming to my office, or I can meet some of you at your office or whatever, and we can have a smaller session where a handful of people are together where I help them deliver the splint. Number one. Number two is maybe I can show people, demonstrate to people how I use my disc to shape the anterior teeth. I use the discs primarily for anterior teeth to make the embrasures, to make the incisal edges, to make a little bit about the aspects of the aesthetic management of the provisional teeth. I think that can give people the next level of comfort that they are looking for. Okay, Mylene, before you do that, I don't know, Marty, if I satisfied your raising hands a couple of minutes ago.
Yeah, thank you. I just wanted to know if you want to keep this talk in recording.
Oh yeah. I think so because I want the people who are gonna be listening to this, hopefully, they know what we talked about. It's okay.
Okay.
I think we should continue the recording. Yes. Okay. All right. Thank you. Mylene, comment, question?
Yes, I was wondering if that live session might include a demonstration on capturing CR.
Oh yeah, sure. Yeah, I mean when we are doing splint night guard fabrication or delivery, it gets automatically built into verification of the CR. So yes. And I'm willing to even like make it coincide with when I'm traveling. I don't know, Mari, out of the rest of the people who are joining in, I don't know how many people are in Chicago area with you. If there is at least one more person, maybe we can make it. I was thinking about going to Chicago for a pros meeting in November, so maybe we can make a plan where I can come into your office and then do something there for the people in Chicago area.
If
Mylene,
you're going to Chicago, I'll go.
huh?
If you're going to Chicago, I'll go.
Okay, well, that's a good
Howdy,
excuse.
your office is in Chicago?
Marty's office,
You're in Chicago, in the city?
I'm an associate here in the city of Chicago.
downtown.
Oh, great. Yeah, I used to live there. I lived there for like a year and a half
Oh,
Oh,
on
okay.
Lincoln Park.
Lincoln
nice.
Park,
That was
yeah,
a long
sure.
time ago.
Yeah, I didn't know that. Oh, okay, man. Okay, yeah. So, yeah, something like that. I think maybe in addition, not as a replacement of our normal sessions, but an additional session where we can do that. I think that will be helpful. And then maybe people in California, I can have them come to my office, and then we can have a group session there or something like that. And hopefully, if it's only once or twice a year, maybe people can plan for that and make it happen. Because I realize that some sort of a hands-on to supplement what we've been talking about is critically helpful. Okay, so yeah, I've been thinking about back and forth, back and forth. The upcoming meetings that I am thinking about going, I don't think I had a chance to tell you. And all these are fine, Marty, for us to record because people who are not in this right now, I want them to hear about what we've been talking about. I recently actually had a chance to attend 2 days of workshop for water lays. And it's nothing new, but Waterlace has been updated quite a bit, and it's not just for drill-less prepping of the teeth, but there is a tremendous application for surgery, and then perio treatments. So I got really excited after 2 days of course. So in case if either one of you are interested, um, I am interested in attending. They have an Academy of Laser Dentistry meeting in Vegas in October. So I'm thinking about attending that for 2, 3 days, and then go to Chicago American College of Prosthodontists meeting in Chicago, November 11 through 14. 11, I think, is just board preparation. So 12 through 14, Thursday, Friday, Saturday. I'm thinking about going there. I was kind of on the fence. I believe it or not, I wanted to go to a laser meeting more than pros meeting this year because I'm contemplating if I should make the investment to have $100,000 laser machine in my office. The problem with these things, laser thing, is just so expensive. That's the problem. But at least that's what I'm thinking about anyway. Um, um, if you're interested, American College of Prosthodontists also have what they call Digital Dentistry Symposium, and that is the just all things related to digital stuff. And this is virtual meeting. Okay, so you don't have to leave your office or your location, but it is during daytime, and it's gonna be in August 27, 28, 29. If you go to American College of Prosthodontists website, and they'll give you a little bit of agenda of all the topics that are in it. So frankly, I was thinking about going to signing up for the Digital Dentistry Symposium and not go to Chicago in November. But let me kind of filter that out in my head, because uh, one sign that I have that I guess I'm getting older is um, I'm not looking forward to traveling that much anymore. You know, I used to enjoy that, but I'm like, I'm getting lazy. So we'll see about that. Okay. Any other topics, questions that you want to mention, or anything else? No? Well, yes.
I do have a question. Are there studies, are there scientific studies on anterior contact and TMJ? Like
I'm sure there
how
are.
heavy it is?
I'm sure
Like
there
you were
are.
saying, the
Well,
quality or the
for instance,
quantity, the heaviness of the
yeah,
anterior stuff.
exactly. So there are a lot of studies that says that if you have anterior contact only, meaning you take away the posterior contacts by either just restoring the front teeth or having anterior splint, okay, that people's biting forces get reduced. And after all, that's where they got the idea about NTI or Lucius jig or anterior jig. But here is the thing. My take on that is misguided. So there is absolutely, it's almost definitive that you take away the posterior stop and you only force people to have anterior stop. At least while they are conducting the test, they cannot generate as much biting force. And that's where people get the idea, well, you got to give them anterior guidance so that they're not clinchers. It prevents them from clinching. Okay. But those studies are done only when they are awake, obviously. Right? Electromyography, okay, EMG, right? That's number one. So nighttime nocturnal clenching, it doesn't really influence that much. That's number one. Number two, why are people not able to produce as much clenching force when only the front teeth are touching? It's not a magic where the brain says, oh, I'm happy with the front teeth, so I don't need to clench more. No, it's not that. When the front teeth are touching only, perhaps, now this part I'm not aware of, study, but perhaps it's because it's a reflex. Our body says, I don't want my front teeth to touch only. So they open up or they don't clench as hard because they know it is inherently unstable and inherently not good for your front teeth. It's kind of like if I have my fingertip and if I go touch a nail tip, a pin, something sharp, knife, and if I try to push on it hard, there is equal part of my body that says, don't do it, don't do it. And I don't really want to touch it too hard. Right? But dentists don't think it through that much. They only make the observation. If our front teeth are touching primarily, then they don't clench as much. Therefore, that's what we need to do. No, I disagree on that. So this is why, Mylene, I caution people from just reading things and taking the articles at their face value. You have to really think it through. The literature review means we have to think it through and see if their design and not only the results, but their discussion and their interpretation, their conclusion is something that I can agree with. In my opinion, all those studies about anterior context are completely misled because they all come to the same conclusion. That's why that's why so many people don't talk about posterior occlusion because they rely on those studies. But if you leave people with strong anterior contact, what happens? They break off. You develop fremitus. You develop TMJ. You know,
Are there studies that show like I'm thinking of research ideas. Like, are there studies that show relationship of fremitus, fractured restoration, and lack of posterior stop related to the TMJ? Are there studies like I'm thinking of research options, in the future? Are there predictable scientific
I would
studies
imagine
that
there are some that indicate those things. So the challenge, Mylene, for doing study with TMJ and occlusion is that it's such a complex inner relationship and the the design of the study has to be really, really well done. And the conductor of the research has to be very well calibrated person. Um, I certainly don't pretend to be a world authority in all the research that's coming out. I will be curious if you do yourself a Google Gemini search and tie it to PubMed, okay? That um, oh my God, this Gemini is getting crazy. My phone just started listening to me on its own, and it says, "Would you like me to continue monitor what you're speaking?" God, this is scary. This AI stuff is scary. Okay. Not only it initially the screen came up, but it started talking to me. Would you like me to? I'm like, what a world we live in. This is why I don't like to talk to my phone. Anyway, so if you are interested in a study that you want to design something, um, I would like to suggest that you make it as simple as possible when it comes to occlusion. If you try to come up with clinically kind of encompassing study, it is going to be very, very difficult to design a study that's satisfying. And what I would do is to do your own initial PubMed research, PubMed just web surfing, even with just utilizing Google or Gemini, and then see what are some of the things that you see that might be interesting. And if you like, you and I can do a Zoom session or just us two of us, and we can go through those things and then sort of whittle through what projects you might be interested in. Okay, thank you. Okay, everybody, thank you so much for your patience with us today. I kind of had a feeling today was going to be a low participation day. So, like I said, I've been doing this kinds of small study groups for well over 10 years now. And I know the pattern. So what can I say? Okay, sounds good. But thank you so much for joining today. It was good for me. Okay, so I'll see you next session.
Thanks, Dr. Lee.
Thank you. Good day. Bye bye.